Amy, thank you for that introduction. And I was in the lobby when you were an MP and when you were taken ill, and I remember how much good feeling and good wishes there were from MPs across the spectrum actually for you. So it's lovely to see you again in your new life and to see you thriving as well. Well, thank you for coming to this next session, which is Hard Choices, the reality of a rationed healthcare system. I'm really excited about this discussion because I've sat on many panels over the years where everyone talks about how their area deserves more money without acknowledging that that might mean that someone else's area may get less. Or indeed, actually, that it might not be all about money. So I'm Isabel Hardman. I'm the assistant editor at the Spectator. I've also written a book on the history of the NHS, which is still available in bookshops, I believe. I'm joined by a wonderful panel, and they are so experienced and so perfect for answering the questions that we have before us this morning, that their bios would actually take the entire session to read. So I have condensed them to these very brief introductions. Jane-Claire Judson is the CEO of Scotland's largest health charity, Chest, Heart and Stroke Scotland, and she's also a board member at Public Health Scotland. You've already met Andrew Elder. He's the first geriatrician to be elected as president of the Royal College of Physicians of Edinburgh and is currently also the elected chair of the Academy of Medical Royal Colleges and Faculties in Scotland. Donald Macaskill is CEO of Scottish Care, the representative body for care providers in the independent sector in Scotland. And Angiolina Foster is a highly respected public service leader who has extensive experience of local and national government, and she has worked in a range of key policy areas, including health and social care, communities and housing. Now, we're going to be talking about the nitty-gritty of health and social care funding, more specifically and painfully, the trade-offs involved in both. Each member of the panel is going to speak for a couple of minutes. They're going to be making a hard choice on healthcare in those introductory remarks. Then we will move to a discussion, and then after that we'll go to audience questions and answers. So, Andrew, I believe you're speaking first, and you've even got slides for us.
Thank you very much indeed. And for 2 minutes, read 5 approximately. But thanks very much for the introduction and invitation, not only to be here and host with you, but to speak. It has been said that repetition is the mother of learning. I repeat, repetition is the mother of learning. So I actually don't make much apology at all for repeating a lot of what others have said already, will doubtless say as we go through this session and the rest of the day. And the second general thing I wanted to say is that my perspective today is really that of a clinician. I'm a general physician, I'm a hospital doctor, it's important to say that, and I'm a geriatrician in general. Only a small bit of my perspective comes from the fact that I'm a college president. So because I'm a doctor, I just want to very briefly tell you about a patient. So Mr. AJ was conveniently born in 1948. He's now 77. He's been a taxpayer since he was 16. He's had good health until in 2000 when he was about 52. Then he got really quite severe rheumatoid arthritis, treated by the then new biologic drugs. And not only did they make him feel better, they were so successful, they enabled him to go back to work. He then had a large myocardial infarction, heart attack, when he was 60. Again, a new piece of kit, drug-eluting coronary stent at that time, not only saved his life, but again enabled him to regain health to go back to work. He then got colonic cancer just after he'd retired, and again he had some new treatments, some biologic drugs for his cancer when he was 67. 10 years later, now 2025, he's free of cancer. He is physically frail. He's got early dementia. He's on one waiting list for cataract surgery, but he's starting to need social care support. Here's 5 points of importance about that simple story. In orange, we've given him the chance to grow old. And I think we all too often forget that that is a triumph, not just of medicine, but of our societal changes. But it's a triumph that we're risking turning into a disaster. Second, in green, many of the treatments he's had since 2000 didn't exist before 2000. In blue, the new treatments that I mentioned to you, they were all funded as a result of prioritisation decisions. And somewhere within that, if something got more money, something else got less in a fixed funding envelope. In purple, all the healthcare he received was totally free. In green, he'll be means tested for what we call his social care. So in the past 25 years then, we have doubled healthcare expenditure, we've expanded the number of people we can treat, and in doing that we've raised public expectations, arguably more of cure than care. But what we've not done, I would say, is reform social care. Over the next 25 years, what's going to happen? Well, the number of patients just like Mr. AJ are going to increase. Their expectations, in my opinion, the opinion of the clinicians I work with, will not reduce. More and more new treatments, as was highlighted earlier, will appear every year, and the costs of those will not decline. And finally, the need for social care in this ageing multimorbid population will not decline. So against that background, do we really think that we can sustain these founding NHS principles? Well, that's what we're going to be discussing. But I think the one we're going to struggle with is comprehensive or universal care. Because I believe that if we stick with a fixed funding envelope from general taxation, and we don't redistribute where the taxation income goes, in other words, give more to healthcare, it is not possible for us to go on saying that we can do everything for everybody all of the time. That is not possible. I think we need, in closing, 3 serious conversations. We heard about the so-called, first it was going to be a national conversation about prioritisation. First Minister, I think, was who then renamed it a serious conversation. But that is, how do we spend what we have available? Because collectively, and that's patients, professionals, the public and politicians, the 4 Ps, we need to talk about what healthcare we can and cannot fund. The second serious conversation really is a plea to our politicians. Healthcare professionals at the moment are being told, maybe quite rightly, that you need to work in new and different ways. Well, we're up for that. Yeah, we'll all try and do that. But surely our politicians need to work in new and different ways. And by that, I mean cross-party working, as we heard earlier, longer-term planning, and because the way that our politics impinges on healthcare at the moment demoralises its staff. And I'd go as far as saying there, I don't think there can be meaningful NHS or social care reform without political reform of that form. And then finally, the third serious conversation that we need to have, and I think Donald, who's going to follow me, will maybe pick up on this, is that the division between what we call healthcare and what we call social care is anachronistic. It's from Victorian times, and it results in great inequity and unfairness. I do feel that if there is a right to healthcare, we should be talking about a right to social care. And following on from that, healthcare reform really must go hand in hand with social care reform. Thank you.
Thank you so much, Andrew. We are now indeed going to hear from...
Morning, everyone. It's great having Andy Elder set you up. So, social care, we've hardly mentioned it. What is it? That's one of the problems. Because in so many conversations, the public don't understand what social care is, and dare I say, some of those who lead us politically, policy-wise, also don't understand what social care is. I'll tell you what it's not. It is not there to be the servant or the stopgap valve or the release pressure mode for the NHS, whether that's delayed discharge, avoidable admission, or long queues in accident and emergency. Social care, enshrined in our 1967 legislation, is about enabling citizens to achieve their fullest potential by being as independent as possible, living in their own home or in a homely setting. It is not about maintaining people. It is about quite fully and flourishingly enabling people to thrive. But what we're doing at the moment is the elastoplast social care. So Andy is quite right. We will never sort the challenges of the NHS if we start with the National Hospital Service. We will only sort the challenges of the NHS if we start with a holistic understanding, a whole system understanding of the absolutely intrinsically close relationship between social care and acute, secondary and primary care provision. So when COSLA on Friday called for an additional £750 million to immediately be allocated into social care, they echoed the sort of statements and sentiments that I and colleagues in the independent care sector and the third sector have been arguing. This is not because there is a glaring ineptitude in the way in which we are spending resource in the NHS. It is because if we're serious about that transfer of care, about ensuring a preventative approach to health and well-being, we need to consider the whole system. Attending to the needs and the priorities of one part of the system will only make that part of the system more efficient, whilst it makes the whole system less efficient. So when I speak in the Highlands, Andy and I were both in Fort William on Friday at a similar event to this, and when I speak to somebody who says to me at the age of 87 that the only thing she wants is to be able to stay in her own home, where her husband died, where she brought up her children, where in the village that she lives in, she is known, she doesn't have to explain her story, her identity. When she tells me she will probably not be able to do that, but will have to move into residential care 120 miles away, stripping her from community, stripping her from relationship. That's the crisis of social care provision at the moment in Scotland. Yes, there's a monetary crisis. Yes, there's a workforce crisis, not least as a result of some of the most recent changes to the immigration ability of recruitment in Scotland. But the real crisis is a crisis of dignity. If we're serious about enabling people to thrive where they want to remain as parts of their community, then we have to invest in social care and see social care investment as real preventative care and support, enabling people to have choice, control, and agency. And then ultimately, we save the NHS. But if we don't focus on social care first, forget it. Thank you.
Thank you so much. I'm bobbing up and down like a rabbit in and out of rabbit holes, so it's Angiolina's turn now. You can stay at your chair if you wish, or you can come up here. It's totally up to you. You come up here. It feels more important up here, to be fair.
Yes, I feel grander up here, but also feels slightly more equitable in terms of my balanced view of my audience. So a little bit of me wants to simply say, I agree with Donald and take my seat again, but that would be cheating. Isabel invited us to make this about what would our hard choice be. So this is mine. I think we have to stop talking about the health and care system, firstly as two parts. That's the I agree with Donald point. But there's a third bit that we're not talking about enough, and it is creating health. Yeah, so the current language for that is, I'm glad to say, more and more the language of prevention. But let me put it very simply. If you were all sat in your houses cold as winter approaches, and you decided your central heating boiler wasn't powerful enough, it wasn't putting enough outputs of heat, but you were living with all your doors and windows open, would you try to find a way to buy a second boiler and double your expenses? I think not. You would close some windows and you would close a door or two. In other words, we have to elevate the creation of a healthy population to the same level of adoration and attention and energy as we have, for very good reason, elevated the delivery of our healthcare system. That's my first choice, as it were. So it's great that we have prevention in the language of all the documents that were referred to earlier. Clearly, the hard work of delivery starts now. Why is it going to be hard? Here's one key reason. The creation of those documents demonstrated to me that the hard work, advocacy, debates, blood, sweat and tears of many people over the last few years have won the argument in support of prevention. But more accurately, within the health and social care community, have we yet won the debate with the general population? Absolutely not. So major job of work to do to take that narrative out there. Where is the outrage in our population about the state of Scotland's health inequalities? Where is the angry protestations from parents demanding a safer food environment so that they can bring up our children on a less dangerous and ill health creating diet? So there's lots of work to do there as well. But just as the answer to this challenge cannot be that none of us has the answer, right? We cannot look at one another and say, the job of changing the public discourse is somebody else's job. I firmly believe we all have a part to play in that. We can't just advocate for our bit of the system. So to our clinical community, I say well done for the eloquent, persuasive case you are making for more resources in your profession or in the NHS. I would love to hear your voices raised in support also of the primary determinants of health. I'd love to hear your advocacy for, say, early years or that safer food environment. Some of our earlier comments this morning were punting some of these issues upwards to our politicians. I think that's a little bit lazy of us. Indeed, I think we're abdicating some responsibility. It's actually quite cold and dangerous for the average politician up there, where we tend to bung the hard stuff. I think we all have to take responsibility for, Sarah's word, de-risking some of that for them. So I invite you to reflect on what your role might be in helping to change the public understanding so we can bring the public behind us in some of this mission that we all know we cannot fail in. And whilst I'm on language, could I just make a little point that's a bit of a challenge to both some of our senior managerial leaders and indeed some of our political leaders. I hear all too frequently the following. People speaking about the investment in our NHS and the cost of social care. I respectfully invite relevant colleagues to reflect on your choice of language there and what may sit behind it. Because to much of what Donald said to us, I think that distinction between investment and cost is one of the major things that we need to rethink. My other comment that I just want to say very briefly is that I know we're largely a bunch of Scots or adopted Scots, and we love a right good moan, right? So let's get it out of our system. But once we've done the gurning, can we please recognise the phenomenally privileged and opportunity-laden moment that we are in? The documents that were mentioned earlier are the new policy environment. We have clear, explicit commitments to a 10-year horizon, to changes in funding and performance management and accountability systems to support a system of prevention, or health creation, as I prefer to call it. So that is a moment, let us not squander it, but also let's recognise what we are already doing well. We actually know how to do this stuff. I was so grateful to hear Kirsty and then Paul Johnson remind us we do prevention. And let me just remind you of our history, which is seen as a global case study of how to do it in tackling tobacco harms, right? Classic combination, top-down, brave government regulatory activity driving it, and then supported by good, sustained, on-the-ground support for citizens. and look at the transformation that's achieved. We know how to do it. Let's get on with it. Final thing I want to say is that I want to share one of my deepest bits of learning in my working life in the field of transformational leadership. Change happens at the speed of trust. Yeah. The quality, the pace, the effectiveness and the sustainability of any transformation, I have found, happens in direct proportion to the quality of relationships between the people in key positions of stewardship. So I just invite us all, myself included, to regularly ask ourselves, what are we doing to invest in those relationships and earn that trust? And that will be the wind in the sails of some of what I think we know we need to do. Thank you.
Well, thank you so much for that very provocative set of points. So I think we're going to have a really good discussion once the panel's done. I have to say, as an incomer, I don't recognise your picture of moaning Scots at all. You're all very upbeat. So Jane-Claire, it's your...
Thank you, and I've really enjoyed this morning and listening to the discussions, and I think it's really informed certainly some of what the panel has already said, and Angiolina Foster is a fairly hard act to follow, it has to be said. One of the things that I would like us to do in terms of hard choices is one about language. I want us to stop saying that the NHS is unsustainable, because I don't actually believe that. I think that our approach to the NHS is unsustainable, because the NHS is made up of systems that have been designed by people. It's people that run the NHS, that deliver the NHS and that engage with the NHS. And so I think by saying that the NHS, this magical system out here, is unsustainable, is essentially saying that we're not taking responsibility and accountability for that. It is our job to make it sustainable if we think that that is not happening. So I would like us to change our language around that. There's two areas in which I think that resources should flow that would tell us whether we're getting that right. One is prevention, which I think has been well rehearsed. I'm certainly not going to try to follow Angiolina on that. But one thing I will say is that we need to start to see the resources flow and to see them, as the Auditor General would like to see, on the balance sheet. As an organisation, we were not investing in prevention at all 6 years ago, but now 10% of our budget goes into that. We have made that shift as a third sector organisation, and I challenge you to do the same. If I can do it, then you can do it, and we can also do it together and find those ways to get that money out to the people who need it most, so that I can spend my resources on the people where it was avoidable. I would also like to talk about the inverse care law. That's not about taking money away from people, but it is about making sure it goes to the people that currently aren't getting the same treatment depending on where they live. And I do think that that is wrong, and we need to find a way to track that money and to make sure that resource is going into those communities. The final thing I'd like to say is about decision making. This morning we've heard about politicians making decisions, clinicians making decisions, policymakers and civil servants making decisions. I have yet to hear about the third sector making decisions, or indeed our young people, indeed the people that are actually engaging in the service. We need to cede power and cede authority, and we need to engage more people than just in this room in this conversation. And that's the big change that I would like to see. But it's a hard choice for us to do and to create that trust and confidence. Thank you.
Thank you so much, Jane-Claire, and thank you to all four of you for kicking us off with your thoughts. Just to allow you to respond to one another in a little bit more detail, I suppose if one were being cynical or downbeat, one might look back over the history of the NHS and say that politicians and health leaders have always wanted a preventive agenda, but have never really managed to fully execute it because of the important and urgent crises that are so often befalling the NHS. And really prevention was something that Nye Bevan baked in his vision, but wasn't really able to bake into the implementation of the NHS from the start. So I suppose my question, probably to Angiolina to start with, and then to see what the rest of the panel thinks, is what makes you think it's different now?
Thanks, Isabel. Here's why. The NHS has a role in prevention, but many experts, people far cleverer than I, there's a reasonable consensus that at best, the NHS's contribution to someone's health is about 20%, right? 20%. And this is part of the huge shift in professional and public understanding that I believe we need to achieve. It's the other stuff that has to contribute to a huge shift in population health. It is education, it is schools, etc. It is a decent job. You know, what a surprise. You give someone a job in a warm house and their health and well-being improves. That is not a job for the NHS. Do you see what I'm trying to say?
Absolutely.
So that is one of the ways in which we're coming at this problem that has to change. And I think the public are worried that this might mean closing a hospital in order to pay for something else. That's the wrong way to come at this stage in our development. It's the other services that we have to understand their contribution and support that. Hence my comments about asking clinicians to raise their voices, for example, in support of early years.
And Donald, I don't want to suggest that social care is in any way an other service, because this is very much a discussion about ensuring that the NHS and social care are considered together. But in terms of the preventive approach that must be taken to enable social care to be a preventive service that stops people having to go into acute services so often, what are you seeing any signs of optimism?
Yeah, I think, I mean, you're a historian of Bevan and the period of the establishment of the NHS. At the same time, though we often forget, modern social care was established. And he didn't necessarily use, and the Parliament in the time didn't use the word social care, but it did talk about community care, it talked about home care, it talked about supporting people in their own homes. And we kept that alive in the Scottish Social Work Act, where we talked about health being about well-being and not just about the delivery of services. It included housing, it included our anti-poverty work. And so what we did have, and interestingly, probably up until we introduced free personal care, not that I'm critical of free personal care, but before free personal care, most care and support in an individual's house was preventative, 68% of it. And because of budget constraint and other mechanisms, that has depleted. But we were a system where the carer went into somebody's own house, noticed that the person was walking a little bit unsteadily, noticed that they weren't eating the same amount of food, noticed they weren't drinking. That was preventative care and support, because usually she would contact the GP or the pharmacist or the family member. So we've always done preventative care within social care. And I suppose moving ahead, what I see very positively at the moment is the use of technology, projects like the Care Technology Project, which enable devices which people have in their own homes, like your Alexa or I shouldn't name one particular device, but there are other devices which help to connect people up, reduce loneliness, monitor the risk of falls, ensure adequate hydration. So we have tremendous potential of enabling independence and enabling better health outcomes which prevent people from unnecessarily being admitted at an earlier stage than they need to into our acute and into our secondary system. But we need to join up the dots and recognise social care and primary care and our acute and secondary care as part of a whole system, not a disparate parts of the same.
And Andrew, I suppose coming on to you, I mean, how do we ensure that people are getting the right service at the right time, and that actually they're not ending up in a hospital, they're not ending up with a geriatrician waiting to find a suitable location for them to be discharged when they're medically fit?
Well, I don't know. What I would perhaps reply to sort of illustrate, I think, what you're getting at is the problem of the challenge of delayed discharge, which has been a career-long challenge for me, and it's not getting any better. I had the great joy of, some of you will remember, filing cabinets. I cleared out an old filing cabinet in an office the other day and I found a brown manila folder labelled Delayed Discharges in Lothian 1998. And you know, every point in it was relevant to today. All the proposed solutions were there. The names of some of the organisations were different, but the problem has been there. And for some reason or another, I don't know actually if it relates to the fact that the people we're dealing with in that situation are old. WHO has suggested that all healthcare systems have implicit ageism within them. Maybe it relates to that. But the fact of the matter is, it's a 40-year problem that we've been unable to solve. And I'm interested in other people's views. Why is that? Yeah. I don't want to blame shift. Is it clinicians not speaking loudly enough about the problems that they see? Is it our failure to join up well with social care? Is it us not saying it loudly enough to politicians? I don't know, but it's there.
It's an interesting point just about the ageism within the system, and we don't want to kick blame up to politicians all the time, but sometimes perhaps it is relevant, and perhaps it is also a reflection of the society that we live in. I imagine as a geriatrician you have not had as many visits by politicians to your wards as your colleagues who work in oncology or special care baby units. I mean, they do tend to be the more favoured parts of hospitals when a politician is doing a photo op. And I wonder whether that's a reflection perhaps of, you know, shiny new machines in those specialties, but also actually the emotional response that our society has to a baby versus an old person. And whether that's something we can ever change, or whether that's something we can sort of militate against within this sector.
Yeah, well, I'm sure, and there are numerous studies that show that in situations of crisis, humans will favour the young over the old. That's a natural response. And I'm not, as a geriatrician, advocating that we should prioritise everything towards the old. I'm wanting to ask the question, if you have a limited funding pot, who is it that decides how much money goes to cancer services, how much goes to cardiovascular care, how much goes to community, how much goes to hospitals, how much goes to mental health, how much goes to physical health, how much goes to rural, and how much goes to urban? It seems to me we've never had a mechanism of really trying to knit all of those together and make informed choices about how we want to spend our limited pot of cash.
Jane-Claire, your point about progress moving at the speed of trust, I thought that was so powerful and so interesting, because I just wonder whether actually, sorry, I've attributed that wrongly. It was your point, Angiolina, but I wonder whether you agree with that, firstly, Jane-Claire, but also whether the points that Andrew just made about those lessons within that folder in the filing cabinet remaining unlearned, or at least the problems remaining unsolved decades later. What is it that we can do to improve those relationships between third sector and between primary care, between acute care? What's your take on that?
First of all, I'm just really privileged to be taken for Angiolina's commentary there, because I think she's absolutely right.
I'm so sorry.
And I thought that the trust comment really got to the heart of a lot of what we're talking about. I think from a third sector perspective, there's a couple of things I would like to say. I think in terms of the discharge issue, one of the things that we certainly find as a charity is the referral system within the NHS is just utterly Byzantium in terms of trying to navigate it and trying to build trust with health boards to create referral systems where people can be discharged into the third sector. So to give you an example of that, if we operate across 4 conditions across the health boards, the IGBs, the local authorities. Every time we negotiate a contract, it takes us 18 to 24 months to get that into place due to governance, data governance and clinical governance issues. And that takes up a huge amount of time for us and for the NHS. Now, some of that is technical, but some of it's trust. Some of it's the idea that the patients are owned by the NHS. But they're not. They're individual people who own their own lives. So we have to build that trust, but that quite often is very much seen as a third sector burden to prove that we are able to take those patients on. Whereas if you ask Sue, who you saw earlier, she will tell you that's the support that she needed. and it wasn't there because we're not joined up. So I think that's a clear issue there that we need to work on around trust. I think there's also something around trust around can we have appropriate conversations that are respectful and professional, and then we stick to those conversations as we leave the room. And that's hard because we all go out and go, gosh, did you hear what so-and-so said? And this sector wants this and that sector wants that. But we need to have a shared narrative. If we've got a shared goal, then we need to be able to put that aside and to be able to move forward as a team. You know, and I use that word kind of lightly, but you know, we need to be a team on those issues. The final thing I'm going to say is a little bit about the money. So 21 billion. I mean, I know that we'd always want more for the NHS, but it's not a small amount of money. It is about how we use that wisely. And to give you just a little bit of an idea around that, the amount of money that goes into the third sector from that is only 321 million. It's less than 2%. So when we're working with you and trying to do that in partnership and trying to do that with trust, that inequity or that perceived inequity around funding is really stark for us. And we're coming to you saying that we have things to offer. We have capacity to offer to you to ease the strain that you're under. So I think we need to be upfront about that and to work together on those issues.
Angiolina, having accidentally attributed your quote to Jane-Claire, I do apologise, but also just about the speed and I suppose the lack of trust within the system. You must have some further reflections on that.
I do. I, like many folk, were gobsmacked at the rate at which we managed to do a version of reform during the pandemic, when suddenly insuperable barriers fell over almost overnight.
But were they re-erected as well afterwards?
Well, I guess this is my point. And I think what was happening there was less trust, but the alternative to not trusting one another was so hideous and scary for us all that we chose to behave in a mutually trusting way. And I think that should make us all very, very thoughtful now, because we did. Once we all began to feel a bit safer, we pinged back into our previous places of slightly partisan preferences sprinkled with a little bit of a tendency in a so-called partnership to blame the partner that wasn't in the room today. Yeah, do you see what I mean? Mm-hmm. It's so this, at its heart, I think, is about really understanding what accountability means and the fact that it includes us as well as the folk whom we also need to take it seriously. So I think that is a very useful conversation to have now across health and social care, to air some of the stuff that bubbles under a lot and just ask ourselves, you know, why are we in this game? And can we get over ourselves a little bit, because both the prize is big enough to get over ourselves, but also the consequences of not doing so are pretty hideous.
Donald, you were nodding knowingly there, and I suppose we can't have policy making on the basis of being frightened all the time. That wouldn't be good for anyone. So how do we have the sort of alacrity of the pandemic without the threat?
I think it comes from relationship and value. Like many people in this room, I have and I'm going to be again giving evidence to the COVID inquiry and in Scotland, and as part of that exercise I've had to read my 20 diaries which I wrote during the first year of the pandemic. And what struck me from that, apart from being a hard read, was the trust, but also the respect and the value and the shared sense of openness that we had with each other. In other words, I didn't assume that I was always right, I knew all the answers, or that I knew what that person was going to contribute. And I think we've lost sight of that dynamic. So Angiolina's absolutely right in that regard. And I think it's very important that we recognise trust doesn't just happen, it has to be worked at. It's easier to build trust in a crisis than it is to build that trust in normal times. And we are in normal times. But as some folks in this room know, I spent some time in Australia last year on the back of their dramatic aged care legislation, which has completely transformed health and social care, or what they call aged care delivery. And the minister involved in it, I asked her, why did this work? And she said, because we trusted each other. And because we knew that this wasn't about vested interest or narrow concern, this was about what we all wanted to achieve, which was, in their case, that Australia becomes the best place in the world to live in into older age. We need to have that same sense of whole system, shared vision and one direction, and then build the steps of trust, respect and knowledge, and not to presume that each part of the system knows what the others are doing. And one voice I think is often missing, which Australia put at the heart, and that is the 850,000 people today in Scotland who are unpaid carers, who are the backbone of all health and social care delivery, and who very rarely have a voice and very rarely have a presence.
We're talking a lot about people trusting one another, and I think I'm going to be slightly rude and ask you, who don't you trust at the moment, and who do you feel doesn't trust you? Just to make it a bit more specific.
I didn't realise this was a therapy session.
Yes. That's what journalists are for, isn't it?
Okay, so if I am critical, as I'm quite often publicly, I'm critical sometimes of the opportunistic nature of our political system, which makes it very difficult for politicians publicly to say what they often know privately and what they will say to each other privately. And so the success of what happened in Australia, and I know a bit about what happened in Denmark, I know a lot more about what's happening in Ireland, is to, as has been used before, give space to our political leadership to know that we have their backs in situations, which has already been referred to earlier. And I think we need to move, and it's not going to happen before the election, but I hope after the election we will get to a position where politicians are able to join a commission, a committee, a group, because we all broadly know the direction of travel we need as a society, social care and health to move in. We just need everybody to hear each other's voice, to trust each other's position and to collectively move forward. So I think there is a real ask of political leadership to, when the time is right, to park the partisanship, to recognise you wouldn't get everything, we wouldn't get everything we want, but our aspiration and end goal is most important.
I think that's such a challenge to politicians, isn't it? Because they obviously work in electoral cycles, and that's unavoidable unless we want to move into a dictatorship, which we probably don't. But I was in Guernsey a couple of years ago, and the taxi driver found out what I did, and he said, "What we really need is a banal dictatorship." And I thought that sounded, through a slip of the tongue, quite appealing, actually. But given that they are beholden to electoral cycles, for politicians, it's very hard to find the right time to level with the electorate about these questions. And I think that's the point you're getting at, isn't it? That actually they do know that there is no solution to social care funding that is going to mean that taxpayers are paying less at some point, whether it's upfront through tax or upfront at the point of care and so on. And that was the lesson that Theresa May learned when she tried to talk about reform to social care in England in the 2017 election, was she thought that she was in such a strong position that she could be honest with the electorate. And I remember talking to Labour MPs at the time who were saying, well, the system she's proposing, actually, it's not the worst one, but I'm about to lose my seat, so I'm going to go and call it I think it was a dementia tax, that one. But we've also had the death tax, and with every new proposal for social care reform, there's a politician on the other side who is thinking in existential terms about their own job, who is perfectly prepared to go against what they, as you say, privately might agree with. So that is it's a huge challenge to the way in which politicians and the media operate. Andrew, who don't you trust? And who, given we're having a relationship counselling session here, who do you feel you could work better with?
Well, I don't trust my plumber right now today, actually. But putting that aside, and going back to the pandemic, first of all, I think there was more trust and respect and value there. And maybe that relates a wee bit to, I think it was one of the things Angiolina said about having and you just said about a single shared vision, because I'm not sure we do have a single shared vision right now of what it is we want. On the one hand, we call the National Health Service the National Sickness Service. Is that our prime mission, to treat people when they become unwell, or are we more into prevention? Should that be our focus? And there's a real split between us. So in the absence of that clear shared vision that we collectively develop, I would say, maybe that's why we're suspicious, if that's the right word. From the pandemic too, I was struck by something I read about when the tsunami happened, that much of the most useful response came from the locality. Yeah, the top-down stuff, A, took longer to happen, and B, actually didn't work as well. It was people on the ground who made a difference. And I think there was a bit of that in the pandemic, that we felt just sort of locally empowered a wee bit more to make decisions. But going back to, who could have worked better, well, I'm critical of us all. And again, I think it was Angiolina who said that this is a shared responsibility to sort all this out. And heavens, we're a small country. We've got a very small medical and clinical community. We've got a very small political community. We take great pride in our talents as Scots to sort things out and to speak to each other. And so I'm left wondering, why can't we do that? One of the great things that's happened in the work that Enlighten have been doing in the last 18 months is trying to create what's been called a safe space for politicians to speak about what we're speaking about today. And what struck me about that is almost all of them have the same ideas. Yet if you read the papers, it's barbs being thrown. I'm not a politician. I've no idea what that kind of life can be like. But from the outside, it just seems so counterproductive. So we need to find ways to support our politicians, because without them it won't change, as I said on my slides there, to help them turn things that are currently, if they speak about them, they're vote losers, into potential vote winners.
I think there's also, there is an issue with journalism in our society as well, in that I think political journalists like me have been given too much sway over coverage. So I thought the example in the pandemic of when the political editors were the ones who were supposed to attend the Downing Street briefings, I thought it was a huge mistake. All the health correspondents went out, and all these mostly men who didn't know the difference between antibodies and antigens came in, and all made it, every announcement was about differences and splits within the government. And dynamics are hugely important because they will stop things from happening. But they're not the only thing that's at play. And you say when, actually you talk to politicians, they've all got the same idea, but it ends up barbs being thrown. It's not just the words that come out of the politician's mouth. It's actually the way in which the lens through which they're interpreted. I'm not talking myself out of a job here, but I do think it's something for us to reflect on, that actually maybe political journalists are, not as important as the specialists who actually know what on earth most of you are talking about, whereas we haven't got a clue, to be honest. Jane-Claire, just before we come to the audience, just your point about the third sector and decision-making, and I suppose coming back to the point about trust, and your really interesting point about the NHS seeing patients as its sort of property. That's fascinating. I'd love it if you unpack that a little bit more for us.
Oh, I'd be very happy to do that. I think that, yeah, I can totally understand it. I think as a healthcare professional, you see someone in front of you and you want to improve their life, you want to improve their health, you'll feel a sense of connection with them. It's such a human thing, isn't it, to be vulnerable and say, I'm not well, this is happening to me, and then to have somebody help you. So I absolutely understand that. I think that we need to go beyond that. I think that the public understand that their life in terms of their health isn't just channeled through the NHS. We're seeing from polling that Mark will take us through later, that the public understand that they need more than just doctors to help them with their health. They need more than just the NHS to help them with their health. And if we see an ownership over people in that way, then that constrains us and it constrains them. But we do see that. And in terms of that trust, it's very much about behaviours. So I wouldn't single out a specific group around that, but the behaviours can be, well, if we pass this health record on to you, and I'm like, it's not even mine and it's not even yours, it's actually the individual's health record. What do they want to happen with their health? What goals are they after? What outcomes are they after? And can we together manage to achieve that for them? So I think there is something that we have to, and sometimes I fall foul of it because I feel very protective of anybody who's come in touch with a Chest, Heart and Stroke Scotland service. They're part of our family from there on in. So I can totally understand it, but we have to remember that there's 5 million people out there living their lives, and we're a tiny part of it, a significant part of it, but quite a tiny part of it. And I think we have to be aware of that. I think in terms of some of the behaviours that I have seen that I think erode trust is when the third sector is not included in the discussions that would actually help frame service design and delivery. So during the pandemic, it's really interesting to hear people say, oh, that the trust was really high. And I'm not going to speak on behalf of all of the third sector, but what I found is that we were needed, and it was expedient to get us around the table really quickly as a third sector and for us to deliver services very, very fast, because we had volunteers and we were able to get out on the ground, sticking to all the rules, of course, to support people who were isolated, who were shielding, who were scared, and we did that work. Now, sometimes that felt valued by our partners in that, but sometimes it felt, straight after the pandemic, as though that trust just went. We were not in those rooms anymore. So what was that about? So the trust that you thought that you had has sometimes then dissipated and gone. There's a question around that and how it is that a sector then recovers from that and then rebuilds that trust, knowing that some of the rooms that they were in and the conversations that we're having, now it's a chain of events to get in front of a minister or to get in front of a lead clinician or to get in front of an NHS leader. So I think we've all had different experiences of trust. And maybe that's where we start. Maybe we start by saying, it's unconditional positive regard. We all come to this wanting to do something better, but let's just acknowledge that we're not all coming from the same starting point. And how do we bring that gap closer together?
I think it's a fascinating question about how we've moved on psychologically from the pandemic, from during the pandemic talking about how this was going to change everything about how we did things, to actually people really still don't want to talk about it, just generally, do they? And they want to go back to the old way of doing things because it makes them feel safer. And it's just really fascinating that's been the case in the way that you were operating right in the centre of it, as well as the way people live their lives more generally. Well, we're going to go to the audience. I think there's a microphone over there. Excellent. So if you could raise your hands, and then I'll probably point at you and try to describe you for the microphone. Jackie at the front here. It's just coming behind you.
Normally my voice is loud enough that it doesn't require this additional amplification, but as the sole politician, I think, in this room, I'm trying very hard not to be defensive.
The others have run away.
But yeah, can I say that there's a lot in what I agree with the panel. So the question for me is, if we all largely agree, which I think Andrew Elder said, politicians all agree, I don't necessarily think that's true, but let's go with that for the moment. And if Scotland is a small place and we all know each other, and that is absolutely true, why aren't we doing better? Is it an implementation gap? Is it a lack of accountability? So if those two are givens, why aren't we doing better?
Okay, great question. And given Jackie's disagreed with you, let's...
So to pick up on the do politicians agree or disagree, my impression of them in so-called safe spaces is that they agree on more than they disagree on. There are clearly ideological differences about, for example, the funding of healthcare. I think we've, in the run into next year's elections, we're yet to see all the manifestos, but in my contact with the major parties, it's going to be pretty similar about what's said, I predict. And then the final thing I would say is, yes, they're unequivocally, if you've been a clinician for, what have I done, 42 winters in the Scottish NHS, there is an implementation gap. There are multiple reports, some really major reports that we've had that don't seem to have translated into substantial action. And I don't know why that is, but it makes me maybe wonder about the question you're asking, Jane.
Yeah, Angiolina, but my sense is often that these reports are commissioned as sort of crisis comms tools in the moment, and then the idea that you'd actually implement them is something that no one's ever thought of before, but I don't know what your perspective on that is.
Let us hope not, Isabel. But to Jackie's question, why are we not doing better? I think it's because up until very recently, by which I mean until the acceptance of the need to make a major swerve into more preventative activities, up until that point, we have been trying to achieve the impossible thing of putting more and more into the repair shop model alone. Therein lies madness and failure for us all. So now is the time to recognise that the starting point of hard choices within the repair shop alone is somehow the dilemma that we can, if we stick enough wet towels around our heads, will suddenly have the idea that has eluded us hitherto. So I think our chances of doing better have improved with the recent policy positioning. We remain, however, I think, to a large extent at the foot of the mountain, looking for a toehold on how to move from acceptance of the need to make that big swerve into what's it going to look like. But is it doable? Absolutely. Absolutely.
Donald?
So if we take it away from health, any analysis of the gap between legislation, policy and implementation usually is narrowed down to vested interest, a dynamic of power, i.e. somebody or a group not wishing to give up power, and a lack of resource and priority. And I will leave to the audience to determine whether any of that might be present within the NHS. But if I use my world, I think in 2013, with cross-party agreement, Scotland legislated the self-directed support legislation. It was, to my mind, and certainly when I have international commentary and calls, held up as being a piece of legislation par excellence. It was a tremendous ability to give the citizen control, voice and agency over what mattered most to them, which was how their social care should be delivered in that context. It has gloriously failed, regardless of different positions. We have failed. And that has been down to, yes, a lack of resource because of austerity, but equally, and Derek Feely articulated this in his report, an unwillingness of different parts of the system, and they were different in different parts of the country, to cede power to the person who most matters, who is the citizen who uses the care and support service. So all of us collectively have to ask, have we defended our position so much that we have prevented the vision of the person being in control from being achieved?
I'm going to try to word this, and I'm not sure I'm going to get it entirely nailed down. I think there's something about buying in the agility that we need to make the decisions and to take the action forward. So in my world, and I'm putting PHS to the side, although I'm aware that some of my colleagues are in the room, so I have no time to not take action. I have no resource to just decide not to take action. I have no, there's no loan, there's no brokerage coming for me or any of my partners in the third sector. So we have a burning platform that is genuinely real. So I can see my management accounts every month and I will know whether I can pay my staff or not. Now, I'm not saying that that means that you're all in a lovely situation. I'm absolutely not saying that at all. I can only imagine what it's like being a director of finance in the NHS. But what I am saying is that we actually have a shared goal here around implementation gap and getting things done. But what you can do is you can bring people with you who are having to push through and having to make that change. Prioritisation is painful. It should feel painful. Like we should go home at the end of the day thinking we've done a hard shift on that. But I have to turn things around in a 12-week penny if things are going wrong financially for us as a third sector organisation. But with that brings the ability to ultimately restructure and change something in a very short space of time. There are experts who can help us do that. When I say buy in agility, I don't necessarily mean give us money, although we will also kind of ask for that. However, together we can actually create that momentum and figure out how it is to get that change to happen. So there is something, I don't know what the right word, it's not inertia, that's not the right word. There's something about the fact that everybody in this room wants to make that change. Can you identify the barrier? Is it agency? Do you not think that you have the authority and the power to do that? Because I have no authority and power, really, as a third sector leader. But I have to find, water moves through rock. You have to find a way to create that change. So I think we need a discussion about what it is that's stopping us from going out and thinking, how do I redesign my team? How do I redesign my service? How do I shift that money forward? How do I talk to partners that I've not spoken to before who could bring that to the table? And then just do some hard things. You know, they will be hard, but I think that that's part of it, is just get something done. I think it was, I'll finish on this, I think it was Barack Obama who said, just get stuff done. The minute you start doing stuff, other things will happen. And I know how tough that is, but everybody in this room wants it. So maybe we need to draw on that collectively to get that shifting forward.
Thank you. Well, I don't need to look for our next questioner because you are ready.
Just using that microphone. A question about funding for Andrew and possibly Donald to comment. I think it's wonderful in this meeting that we're looking at examples of other healthcare systems, because that's always informative. As a fellow of the college, I hate to criticise the president, but with the greatest respect, Andrew, there was one line on your slide when you were giving that wonderful history that was wrong. You said it was totally free. That man had been helped by the health service to get back to work and was paying income tax. And I get very upset when people keep saying that one of the great things about the National Health Service is it's free. I mean, we're talking about it taking 50% of government spending and so on. I've spent a lot of my professional career working with colleagues in Europe. And as most people in this room will know, a lot of the systems, the Netherlands is the system I further rest, have a system of compulsory means-tested health insurance. And the state provide basic care, and they provide total care for people who are on a low income, but people earning anything that is means testable have to have compulsory health insurance. We pay for the National Health Service through income tax, which is means tested. So this argument that it's all free and it should always be free whether you're rich or poor is to me 1948, it's not now. So my question is, would either Enlighten or possibly the college ever entertain the really radical suggestion that we should move to fund our healthcare through means-tested health insurance? The one advantage of that is that the money that we all pay for income tax, which pays for NHS, would be secured for only health and, I would suggest, possibly social services. It wouldn't be at risk in the political agenda of being diluted by requests for all the other things that government have to say. So I can find a very reasonable argument why Scotland would be a wonderful example of how we entertain the idea of means-tested private health insurance. I'd be interested in the opinion, particularly from you, Andrew, but also possibly because it's such an overlap with everything to do with social care.
Well, we talked about politicians saying one thing in public and one thing in private. I think we can probably confidently say that that's not going to be a proposal in the next manifestos from anyone who doesn't want to get shouted at quite a lot, because the discourse around that is very difficult, isn't it?
But this could be Chatham House rules for today, couldn't it?
Yeah, we won't tell anyone. Andrew, what do you think?
So thanks, John. And I was, of course, trying to make the distinction between free at the point of access in healthcare and in contrast to social care, actually, which I think is something we do need to think hard about. From the college's point of view, I wouldn't get in anywhere near suggesting alternate models of funding our health service. What I would say is, what I've tried to say is, can we please speak about it? Because it seems that we run away from it all the time. Your idea is one of several potential changes or ideas that we could try. You've mentioned looking at other countries too. We heard something about one country earlier on. There's lots of other places that are doing things differently. And it's really, from my point of view, about us having that discussion with as many people involved as possible. You know, my 4 Ps, the public, professionals, politicians and patients, as best we can.
On this, Andy and I had the privilege of sitting on the Alzheimer's Scotland Commission last year, which looked at long-term care. And one of the reasons it was established was the obscenity that if I'm unlucky enough to develop cancer, I will have my treatment free at the point of access. But if I'm unlucky to develop dementia, and proportionately that mainly will be women in this country, then I will not receive the majority of my treatment free. I will have to pay, probably having to sell my house in order to move into residential care. So the inequity of a whole system approach, which treats one condition differentially, should be self-evident. So I think we do need to have these conversations. And, you know, again, as a director of the Global Ageing Network, I'm very aware that there are multiple models out there. But one thing we have to be honest about is that we have to stop using the term free, because we don't have free personal care in this country. We have a mechanism which is very, very tightly managed, and now you have to be in a critical stage before you get, for instance, your social care provided free of charge. But if we don't talk about it, we will never achieve what Stephen said in his opening comments, which is a serious discussion about how we're going to pay for health and social care delivery in the years to come. We need to have those conversations, and that's one of the areas which I recognise that in England, the UK government has set up. Baroness Casey Louise Casey is exploring not just the provision of social care and health, but also exploring how are we going to pay for it. I'd like that to be a much more significant conversation in Scotland, even maybe not before the election. If before the election, all the better, because it's quite clear, and again, Mark will talk to us later on, most of the public in Scotland do not understand how social care is paid for. And if you don't know the way in which you pay for something, you don't actually know the value of that thing.
Angiolina, do you want to propose a different model for funding the health service? And
not today, thank you, Isabel. But Donald is, of course, right. There are inequities in Scotland in our funding models that need addressed. That's legitimate. And nothing should be ruled out of hand, I think. However, that alone cannot be all that we do. So I would counsel against thinking that will fix this. From my perspective, that would be like finding a cleverer way to pay for your second central heating boiler, for those who were listening to me earlier, as distinct from closing some windows, by which I mean, for example, tackling some of our, in Scotland, standout preventable health issues. If we gripped our obesity problems in Scotland, we would save, it is estimated by respected people, 4.6 billion a year. There's a tidy sum for more of all that we need to be able to afford. So I would suggest we shouldn't get too lost in the intellectual pursuits of funding models without also looking at the preventative actions that actually the return on investment for something like tackling obesity, phenomenal. Right? You get multiples back relatively quickly. So that's where I think we have to go.
Jane-Claire, just on the funding point, but also on the obesity point, we are in the middle of a sort of revolution in some respects in the treatment of obesity, which seems, from a cynical point of view, to be us medicating ourselves against a society we don't seem to be able to change, but have created ourselves. And I wondered whether you had any views on how we might be able to tackle our long-term dietary problems, inactivity problems, which must feed so much into the work that you do with so many of the conditions that you work with.
Yeah, I mean, I think that could be a whole other panel almost on that. I think there's a couple of things in there for me. I mean, I'm glad that I'm sidestepping the means-tested question. That's really helpful. I think that when we look at health in Scotland, there's a couple of things I think going on in the mix, particularly around weight and obesity. And a person, I'm not that comfortable with the word obesity, although I know it's the word that we use in this particular context. I think we need to look at the whole system and the whole person's life. So we put so many barriers in the way of people living healthily so that they can maintain a healthy weight. So access to food in Scotland. If you're living in some of our areas of highest deprivation, you have the less likelihood of being able to access fresh fruit and veg and to be able to do that in a way that's economically useful to yourself and your family. So actually it's poverty. So we need to be tackling poverty more than we need to be tackling anything else when it comes to those issues. I think as well as such a huge amount of stigma around food and appearance and fitness and who we are. I think the medication that helps people manage their health is obviously, a good thing, right? We want to be able to see medical advances. We want people to have access to the prescriptions that they need. But what I would say is that we're in a society now where the first thing that we would do is to try to do that rather than to support and tackle the social injustice issues that have led to that situation. I would also say, as a woman and as someone who sees, women's heart health and other areas of women's health and the challenges we've got around that, because I think it seems to be only the last decade we've realised it's 51% of the population, and we might want to do some research on that and figure out what's going on there, is that a lot of these issues will particularly hit women. Whether it's because it's mainly women that are deciding how to pull together a shopping list that they can afford for their household, or whether it's the fact that we're bombarded by being told exactly how we should look and how it is that we should present to society. That's a whole spectrum within there. So absolutely, having worked in the diabetes world for a while as well, I totally understand that medication can be helpful as part of a wider intervention, but to be honest with you, it disappoints me that as a nation we've not been able to tackle the root causes and to support people to just live healthy lives as human beings. That seems a real miss.
Yeah. Okay, we are rapidly heading towards lunch, and I think the microphone might be picking up the fact that my stomach is rumbling during a discussion on obesity, which is slightly embarrassing, but we do have time for a couple more questions. You're there. Sorry, I'm so sorry. Go for it.
I had a question / reflection on something that Angiolina said around advocacy. Because I couldn't agree with you more that we could play a much, much bigger role in using our collective voices as a professional group to raise our voice on behalf of people who often have no voice. And some of the reason I think that we don't do that as well as we should is because we're not confident in how to do it well within our professional frameworks or the medical legal kind of backdrop. But when we do it well, and when we get engaged in the work of advocacy, often alongside learning from our third sector colleagues, community link workers, it can be a hugely powerful thing, I think, to reduce burnout, actually, as a professional, otherwise working in a system where you feel you're just not able to make change. So I'm always been interested for many, many years in thinking about how do we create the conditions for clinicians to feel like they can get in and about the work of advocacy, whether it's about talking about the impact of cold, damp housing on people's lives, or the fact that you have disproportionately higher numbers of fast food outlets in more deprived areas, or whatever it is. And how can we, again, the Deep End has done some of this, create resources that can just then be used by general practices or other parts of the system that pulls together in an easy way what does the science tell us about the impact of a cold, damp house on my home, and you just tweak it for your local context and you use that as your letter to raise concern. I think there's a lot of potential there that could really power up our voices in the system to think about the wider social determinants of health and to give us more joy in the jobs that we do, and also to work closer with our patients who I think really feel heard and seen when we get in and about that work.
Thank you. Angiolina, I feel like that's a question to go straight to you.
It made my day. And one of the reasons why I said what I said was because I think clinicians and other groups that this audience can all name, some professions and some groups are listened to more readily and believed more readily by the general population than others. And so I think the potential to be powerful voices in the system is huge. And the thing that was in my mind when I was saying that, I didn't specify it at the time, but here goes. It was, I'm very conscious that at the moment, with some very honourable exceptions, there are some players in the food and drink industry pushing back against efforts of government and society to create a healthier, safer food environment. It's to Jane-Claire's point, this is not the fault of people who eat unhealthily. They are surrounded by, an environment that makes it extraordinarily difficult to eat healthily. And so I think there's real potential for unified clinical voices to face down some of the more shameful pushback that comes from industry who, by definition, have other objectives than greater population health. And I do stress there are some honourable exceptions, but nonetheless that debate is a very real one. Donald?
Incompetent in dealing with microphones. So I couldn't agree more with Carrie. The sector and the staff who experience the reality of issues around weight are the social care frontline workforce. The majority of whom, 86% of whom, are women, and the majority of those are over the age of 40 and between 40 and 60. And I was struck last week, which was World Menopause Day, just how little practical intervention and support we are given to women, full stop, but certainly those who work in health and social care. And one woman told me the story that she phoned her, and this is not a criticism of general practice, but I'll use, because this is what she said. She phoned her GP after having had results which indicated high blood pressure and a technical obesity, and she said in her 50-second conversation that she ran every second day, she knew she was freestone overweight, the menopause was really playing havoc with her, and she was on antidepressants, which resulted in a weight increase. The advice she got was maybe take less takeaways, having had no statement saying that she did take takeaways, try and lose some weight and come back next year. Now, factual, true, and I think is an illustration of the way in which we have created a system where there is so little space for people to sit down. It's the same system which has created 15-minute visits for social care staff to go in, get somebody up in the morning, put a plate of food in front of them and walk out the door to go to the next call. It's a system where we have taken the dignity away from dialogue and not given space or time. And it may be that that individual practitioner simply didn't have anything more than 50 seconds for that phone call and couldn't form that relationship. But in any regard, the system is not supporting people to live the lives which will help them thrive and flourish.
That's a really miserable anecdote, actually, isn't it? That I can imagine coming away from that call feeling totally dismissed, actually, as a person. Andrew?
Can I make a point about prevention? Prevention in general,
you can if you turn your
rather
mic
than
on,
just obesity. I mean, I want to transmit to everybody, and I think it's not just because I am a geriatrician, but this fuels it, how very, very worried I am about the next 25 years. Okay? In 2050, every surviving baby boomer will be 85 years or over. Many won't make that age, obviously, particularly from lower socioeconomic classes, but many will. And I mention over 85 because that's where dependency and dementia concentrates. Of course, we should prioritise prevention. I don't think there's any doubt at all about that. I'm not sure where the resources, if it's meaning shifting from health to education or housing, how we work that out. But of course, we should prioritise prevention. But it will have a lag time. number one, before it has effect. And number two, we will not substantially impact the trajectories of people who are currently in their 60s. Yeah, no matter how much we try.
As in, to a certain extent, the ship has slightly sailed, and we're dealing with decades of failure.
Yeah, so it's cold outside. You know, winter looms again in our Scottish NHS, and we are normalising the unacceptable in many of the things that we're currently doing. We have the oxymoron of corridor care. People, as a matter of routine, being looked after outside dignified clinical settings. And, you know, that is what's ahead in the next 20 years. No amount of prevention is going to substantially shift that. Health and social care has to be to the, for older people, has to be to the front and centre here. By all means, let's shift some money to prevention and some resource and some thought, but not at the expense of what we've called today the repair shop, because it ain't going away for a good few years.
That's a very sobering point. And Jane-Claire?
One of the things that I think is quite interesting in terms of feedback that we sometimes get from our service users at Chest, Heart and Stroke Scotland, you know, we see the end result of a lot of preventable conditions, you know, stroke and heart, COPD, and etc. What really strikes me is when people tell their story is that they don't want that to happen to the next generation. They understand that most of what they're experiencing was preventable. So it doesn't quite solve Andrew's point there, Ed. You know, we will have an ageing population that we will have to deal with. But I think we can have a conversation saying, if we want a different sort of society, we're going to have to make some hard choices. And most people have had a stroke or a heart attack or a cardiac arrest. When they realise that that could have been prevented, they're like, well, how do we do that then? How do we stop that from happening? You know, how do we get that into the system? Because I don't want my kids or my grandkids to experience this. The other side of that is it means that the people where that is completely unavoidable, we can actually put the resource in. You know, we can make sure they do get the best care because there's nothing that they could have done or that society could have done to prevent that. I'd really like to just reflect on Angiolina's point about sort of actors in the system, and I think that's really true. I think that we have to be really savvy about who's operating where and why, and you know, it's difficult to have those conversations, but I think we have to be aware that there are people who will want to achieve a certain thing for their company or their organisation, and that's no disrespect, because I want the same for mine and you want the same for yours, so we have to respect the fact that that will happen. I think that what we have to do, though, is to be a little bit braver about what it is that we do ask from the industry, using the wider terms, and ask them to think about their employees. They're an employer. So the NHS might be one of the biggest employers, but the private sector employs a lot of people in this country. What could they be doing there? What could they be doing better in terms of what they can impact in their communities? My final point, just because I did the research, so I want to use the figures, is that the third sector is actually bigger than the whisky industry and it's bigger than the fishing industry. And it always strikes me, because I kind of think, well, I know how often I hear about certain industries in the media and in the press and being discussed, and that's fine. Well done to them, their PR departments, you know, they're doing a good job there. But there's something about just having a look at, you know, how Scotland is shaped and what do we think should have the most leverage, and what should we think should be getting the most air and attention in terms of the challenges that we're facing. And to be honest with you, that's all our work. I'm not blaming the industry or industry partners in that. They are doing their job and they're doing it really well. So that means that we need to step up and do our jobs really well to make sure that we get that balance in there and make sure that people's lives are healthy and well and they get to the age of 85 and they can get that full quality of life.
Well, we have come to the end of our session now. Thank you so much to our panel. You've all been so challenging and at times upbeat, but also I think really realistic and really, really interesting. So thank you so much to Jane-Claire, to Andrew, to Donald and Angiolina. And thank you to you for your questions and for coming. And I'm now going to hand over to Amy. Thank you.